functional cardio, roll number 51. Our topic for today's webinar is anterior pituitary. So now, let's begin with an animation video to locate the anterior pituitary gland. Now we will move forward to the functions of the anterior pituitary gland. There are basically 5 types of neurosecretions that are: first one, somatotropes. It secretes growth hormones on somatotrophy. It regulates the general body growth and metabolism. The second one is thyrotropes. It secretes thyroid stimulating hormone or thyrotropin. It regulates the synthesis and secretion of thyroid hormone and other activities of thyroid gland. The third one is gonadotropes. It secretes follicle-stimulating hormones or luteinizing hormone. It regulates the development of oocytes and spores and the secretion of estrogen, progesterone, and testosterone. The fourth one is lactotropes. It secretes prolactin, which initiates the milk production in the mammary gland. The fifth one is corticotropes. It secretes ACTH, which is adrenocorticotropic hormone or corticotropic. ACTH stimulates the adrenal cortex to secrete glucocorticoids, mineral corticoids, and androgen. It also secretes melanocyte-stimulating hormone. It stimulates the melanocytes to secrete melanin. Now, I will give the mic to Sarva for the further discussion.
Okay, so TSH. TSH stands for thyroid stimulating hormone. TSH is a secretion of anterior pituitary gland, and TSH is mainly regulated by hypothalamus through TRH hormone. We will discuss that here. So first we will discuss chemistry and metabolism of TSH. Chemistry of TSH, it is chemically a glycoprotein. So it has a glucose part and a protein part. The protein part comprises of two subunits, alpha subunit and beta subunit. The alpha subunit is it is coming from chromosome number 6, encoded by chromosome number 6, and beta subunit is encoded by chromosome number 1. So there are peculiarities of alpha and beta subunit. Alpha subunit of TSH is very much similar to that of HCG, LH, FSH. The application of it I will discuss later. And beta subunit is giving functional specificity to TSH. Then the TSH in human beings is very much similar to that in other mammals. So the mammalian TSH, that of other animals, is also functional in human internal environment. The half-life of TSH is 60 minutes. Its main excretion occurs through kidney. Also, it happens through liver. So its secretion is pulsate. So during night at about 9 o'clock, the secretion starts rising. It reaches its max at midnight and starts declining throughout the day. The rate of secretion. So if we take average of the entire day, about 110 microgram per day is the rate of secretion, and normal plasma amounts are 2 microgram per ml. So the peculiarity of alpha unit, as I mentioned earlier, it is that it is similar to that of other hormones, alpha subunit, and in specific cases where these other hormones are increasing, they can stimulate the thyroid receptors, the TSH receptors, and they can cause the further actions of TSH. So, for example, if the placenta secretes HCG, as you all know, and if there is benign or malignant tumor of placenta, then HCG will rise a lot, and that will cause stimulation of TSH receptors. So, hyperthyroidism is a condition C. So, thyroid stimulating hormone regulation. Thyroid stimulating hormone is mainly regulated by hypothalamus through its TRH secretion. TRH mainly stands for thyroid releasing hormone. The other name for it is thyroid hormone releasing hormone. but yeah. So TSH secretion is increased by TRH, thyrotropin releasing hormone is another name, secreted by hypothalamus circulating T3, T4. These regulate TSH secretion by inhibiting negative feedback mechanism. Another important thing to know is that the T4 action of T4 is enhanced by the production of T3 in pituitary cells. It happens through 5' D2. Then there are other facts about TSH. So the stress also regulates TSH and temperature is also important for regulation of TSH. This chart is this flow chart is showing you how the secretion is working. So basically you can see hypothalamus, it is secreting thyroid releasing hormone. Anterior lobe of pituitary, it is releasing TSH. It is acting on thyroid gland, and thyroid gland is secreting T4 and T3. So you can observe that there is rise in T4 and T3 after stimulation of thyroid gland. This is going to inhibit hypothalamus and anterior pituitary in secretion of TRH and TSH. These raised T4 and T3 amount concentrations, they are going to be used by the body cells, and the amount of T4 and T3 will be lowered down. So that will stimulate only hypothalamus. It doesn't stimulate anterior pituitary lobe as you can see in the chart. So there are some other factors that are regulating TSH secretion. Thyrocytes, that is the cells of the thyroid gland, they also have the receptors of insulin dependent insulin like growth factor 1 or EGF1. So these factors, they are also responsible for regulating and they promote growth. On the contrary, interferon gamma and tumor necrosis factor alpha, these are inhibiting growth. So the exact function of these factors is not well established, but you can see that through cytokines, it implies that thyroid function might be inhibited in response to inflammation, which contributes to tachycardia, that is weight loss. Effects of TSH on thyroid gland. So let's take an imaginary situation where we have removed the pituitary gland. So TSH amounts will decrease, and that will cause atrophy and the decrease in size of thyroid gland. On the contrary, TSH injections can be given, we can be administered, and that will increase the activity of thyroid gland. So T3, T4 will be secreted, iodotyrogens will be secreted, thyroglobulins into chloride they will be secreted. This action is very fast, it happens within minutes, and there is another action, endocytosis of chloride iodide trapping, that is increased within few hours. Blood flow is also increased. If chronic administration of TSH is given, then you will see hyperthyroidism, that is also called as glycogen. So the receptors of TSH. Some of you attended the lecture, so you might be knowing this one. Typically, there are G proteins, and there are 7 transmembrane segment proteins. They are the receptors of TSH. This 7 transmembrane segment protein is also called as serpentine receptor. Why? Because its appearance, it forms 7 groups and it looks like the snake. So these receptors, they activate adenylyl cyclase through GS. There is a type letter there, G5, but it is GS. S stands for secretory. It also activates phospholipase C, PLC. Like other glycoprotein hormone receptors, it has an extended glycosylated extracellular domain. We'll get here soon. There is control mechanism. So basically, as I mentioned earlier, there is basic control mechanism through hypothalamus, TRH secretion, but there is also regulation at pituitary level by negative feedback mechanism of T3 and T4. So this indicates that thyroid hormone inhibits secretion before it inhibits synthesis. So you can see that TSH is still being, T3 and T4 are still being synthesized, but they are not being secreted, so their amount may increase. It is important to notice that among the factors affecting thyroid hormone secretion, temperature drop induces thyroid secretion with less significance. This is applied to adults. So stress plays an inhibitory role in TRH secretion, so it will have a direct effect on TSH. There are some other factors like dopamine, somatostatin, that is growth inhibiting hormone, glucocorticoids. These play inhibitory effect on TSH. So this is applied aspect. I have discussed hypothyroidism earlier. I will also show the chart. So first, let's discuss hypothyroidism. It is the term is exchangeable with myxedema. Why? Because the trophic changes or the changes in skin appearance. Its main cause is defect on thyroid gland, but there are secondary causes like hypothalamic effect or pituitary malfunction. Then among the common reasons for hypothyroidism, the first one is iodine deficient goiter. So what is iodine deficient goiter? Iodine intake is decreased below 50 micrograms per day. That is causing decline in T3 and T4, and TSH is induced. So the second cause can be drugs. Some drugs are iodine trapping drugs. They will block iodine binding and hypothyroidism. So this is just a chart that is showing the line of treatment and certain types of hypothyroidism. We will not go into detail on this. So this graph is showing, this picture is showing you what are the effects of hyperthyroidism on body. So you can see hair loss, enlarged thyroid gland, I discussed this earlier, muscle weakness, disrupted menstrual cycle. This occurs because FSH and LH are being secreted by pituitary, and T3, T4 are having direct effect on pituitary gland also. So menstrual cycle will be affected. Heat sensitivity, increased appetite, sweating, frequent bowel movement, unintentional weight loss, shaky hands, heart palpitations, difficulty in sleeping, and nervousness or anxiety. Okay, so I will be handing over the mic to R.Bokare.
Good afternoon everyone, myself Aditya, roll number 52, and today I am going to discuss on the topic luteinizing hormone. Luteinizing hormone is a glycoprotein hormone secreted by anterior pituitary gland, and its key role is in the regulation of reproductive system. Chemical structure: LH is composed of two subunits alpha and beta, and its structure is similar to follicle stimulating hormone and human chorionic gonadotropin. Role of LH in females: menstrual cycle. LH levels are low at the beginning of menstrual cycle. LH surge just before ovulation. Estrogen level rises, causing LH surge, which triggers the release of ovary from mature egg from the ovary, which is known as ovulation. LH release is controlled by hypothalamic pituitary gonadal axis. GnRH, gonadotropin releasing hormone, stimulates the anterior pituitary to release LH. Corpus luteum formation. After ovulation, LH supports the formation of corpus luteum, which secretes progesterone, which maintains the uterine line for the potential pregnancy. Clinical relevance: LH levels are used in ovulation prediction test and in the evaluation of fertility in both male and female. Polycystic ovary syndrome can involve imbalance of LH and FSH hormone. Role of LH in males: in males, LH stimulates the Leydig cells in the testes to release testosterone, which is necessary for the process of spermatogenesis and for the development of secondary sexual characters in male, like facial hair, deep voice, etc. LH in pregnancy: LH-like hormone, human chorionic gonadotropin, takes over the role of LH after fertilization, maintaining the corpus luteum and supporting progesterone until the placenta takes over. Now let's discuss the LH dysregulation, clinical implications. High LH levels. In females, elevated LH levels without adequate FSH can lead to polycystic ovary syndrome and other hormonal imbalances. In males, high LH may lead to testicular failure, where the testis fail to respond to LH stimulation. Low LH levels. Low LH can result in hypogonadotropic hypogonadism or secondary fertility in both males and females. LH and FSH ratio. The ratio of LH to FSH can be used to diagnose PCOS and assess reproductive health. LH testing in fertility. Blood testing measuring LH, FSH, estradiol, and progesterone are commonly used in fertility evaluation for both men and women. Now I will hand over my Tanvi for the next hormone.
Hello everyone, myself Tanvi Kantrapur, number 56. My topic of discussion is FSH, follicle stimulating hormone. This is another hormone secreted by the anterior pituitary. It is a glycoprotein hormone. It plays a great role in gametogenesis and reproductive functions in male and females. The secretion of FSH is controlled by GnRH, means gonadotropin releasing hormone, from the hypothalamus, and it is inhibited by estrogen, testosterone, and inhibin. Pulsatile secretion of GnRH regulates FSH levels. Now let's talk about the mechanism. FSH binds to the specific G protein coupled receptors on the target cells. They activate the secondary messenger called the cyclic AM, leading to the protein synthesis and cellular response. The target organs are different in males and females. For males, the target organs are Sertoli cells on the testes, and in females, the target organs are granulosa cells of ovarian follicles. The functions of FSH are different in males and females. Let's talk about the functions in females. In females, FSH stimulates follicular growth in ovaries and it induces estrogen secretion from granulosa cells. FSH works with LH for ovulation and corpus luteum formation. Inhibition by inhibin and high level of estrogen. High level of estrogen inhibits FSH by the negative feedback. And in males, it stimulates Sertoli cells to support spermatogenesis and the production of ABP, means androgen binding protein, which maintains high intratesticular testosterone. It is regulated by testosterone and inhibin. Again, the testosterone regulates by negative feedback mechanism. Now let's begin with the regulation of FSH. For any hormone, the regulation is most important for the normal functioning of the body. GnRH from hypothalamus stimulates FSH release. The negative feedback is from inhibin and the estrogen and testosterone, which inhibits the FSH via effects on hypothalamus and pituitary. In females, the FSH secretion varies across the menstrual cycles, while in males, the FSH levels remains stable. Now the applies are continued by the Kanika.
My name is Kanika. My roll number is 55. I will be continuing with conditions associated with high FSH. In females during menopause, that is permanent stoppage of menstrual cycle at the age of 45 or 55, ovarian follicle depletion leads to loss of estrogen feedback. Turner syndrome, that is absence of one chromosome, that is 45 chromosomes are present. Ovarian diagenesis leads to high FSH, where short structure can be seen, folded skin, brown spots, small fingernails, rudimentary ovary, no menstruation cycle can be seen. In males, Kempeler syndrome, that is one extra chromosome, that is 47 chromosomes, testicular failure leads to elevated FSH levels. Testicular failure may be due to chemotherapy, radiations, or mumps. In this syndrome, tall structure can be seen. There is slightly feminine characteristics, poor beard growth, and breast development can be seen. Testicular hypergonadotropic leads to high FSH and LH due to gonadal failure as seen above. Conditions associated with low FSH, Kalman syndrome, that is deficiency of GnRH syndrome, which leads to low FSH, LH, testosterone, and estrogen levels. The features of this syndrome can be remembered by the mnemonic in anomsic. A stands for anomsia, which is loss of sense of smell. N stands for no menstrual cycle. O is oligospermia, that is loss of sperm count. S is sex hormone deficiency, that is loss deficiency of testosterone or estrogen. Midline deficiency such as cleft lip or palate. Inherited, it is X-linked genetic disorder. Cryptorchidism, that is undescended testes in males. Severe stress, chronic illness also leads to low FSH. Hypogonadotropic, that is low FSH and LH due to hypothalamic or pituitary dysfunction, which can be seen on above syndromes. Disorders of FSH. FSH deficiency is seen in hyperpituitarism, which leads to delayed puberty, infertility, osteoporosis. FSH excess can be seen in gonadal diagenesis, which leads to abnormal ovarian or testicular function. Growth hormone will be Prachi.
Good afternoon to one and all present here. My name is Prachi Kondule, roll number 57. Today I will be discussing about the growth hormone. Now starts with the introduction. Growth hormone is also called as somatotrophic hormone or somatotropin. It is a protein molecule that contains 191 amino acids in a single chain. Its molecular weight is near around 22005, and as the name suggests, it is responsible for growth of almost all tissues of the body. Here is the diagram showing the functions of the growth hormone. Now we will be discuss about one by one. So growth hormone has various metabolic functions. It has effects on the metabolism of proteins, carbohydrates and fats. First of all, we will discuss about its effects on protein metabolism. Growth hormone promotes the protein deposition in tissues. For this, it enhances the transport of amino acids from extracellular to inside the cell, such that more amount of amino acids are available and increase in the protein synthesis. We know that for protein synthesis we require the RNA, DNA, and for this growth hormone acts on transcription of DNA. It increases the transcription of DNA to form the RNA and increases the translation of RNA for formation of more amount of protein. Another way for protein increase in protein concentration could be we can decrease the metabolism of protein such that more amount of protein is available. The reason for this could be that the growth hormone mobilizes the large amount of fatty acids from adipose tissue for energy supply. This can be act as a protein sparer. Growth hormone enhances the fat utilization for energy. It has a specific effects on fats. It mobilizes the fats from adipose tissue in the extracellular fluid, such that more amount of free fatty acids are available, and then it is converted into acetyl coenzyme A, and through various cycles it can be utilized for energy. Fat is used for energy preference to use the carbohydrates and protein. Growth hormone decreases the carbohydrate utilization. It decreases the glucose uptake in tissues like skeletal muscle and bone. It increases the glucose production by liver, and it increases the insulin secretion. From concluding all this, we come to know that growth hormone enhances the body protein, it decreases the fats, and it conserves the carbohydrates. Growth hormone has another functions on specific tissues like bones and cartilages. It increases the deposition of proteins by chondrocytic and osteogenic cells that causes the bone growth. It increases the reproduction of these cells such that more amounts of osteogenic and chondrocytic cells are formed, and increase in the bone growth. It has specific effects of converting the chondrocytic cells into the osteogenic cells. There are two principles of mechanism of bone growth. First is response to the growth hormone stimulation, that long bone growth in the length at the epiphyseal cartilages. This growth first causes deposition of the new cartilage, followed by its conversion into new bone, thus elongating the shaft and pushes the epiphyseal further and further apart, and the growth of the long bone will occur. Epiphyseal cartilage is progressively used out, so by late adolescence, no additional epiphyseal cartilage remaining to provide further long bone growth. Thus, no growth of long bone can occur after the adolescent. Another way could be osteoblast deposits new bone on the surface of the older bone. Similarly, osteoclasts remove the old bone. We know that osteoblasts are bone forming cells and osteoclasts are bone removing cells. If the formation is more than removal, then there will be increase in the growth. Growth hormones strongly stimulate these osteoblast cells for growth. Thus, bone can grow in thickness throughout the life under the influence of a growth hormone. Now we will see the effects through the intermediate substances called as insulin-like growth factor, also called as somatotropin. Growth hormone acts on the liver for the production of the small proteins called as insulin-like growth factors or somatotropin that mediate the sum of the growth and metabolic effects of growth hormone. Mainly there are more than 4 types of insulin-like growth factors, and most important is IGF-1, that is also called as somatotropin C. Its molecular weight is near around 7500. Its concentration in the plasma follows the rate of growth hormone secretion. Means when the growth hormone is more, then there will be more secretion of insulin-like growth factors from liver and increase in growth. Children with a deficiency of insulin-like growth factors fail to grow normally, even though they may have normal or elevated growth hormone. Example for this could be the pygmy peoples in the Africa. They have the congenital anomaly in the formation of insulin-like growth factor 1. So there will be a short stature height because insulin-like growth factors have same effect like growth hormone, and it is responsible for growth of long bones. And in these people, there is anomaly in formation of IGF-1, so there will be short stature height. Here is the diagram of the pygmy peoples in Africa. You can see that their height is less than the normal peoples because of this anomaly in formation of IGF-1. Now further topic will be continued by R.Bokare.
Good afternoon, everyone. My name is R.Bokare, roll number 53. Now let's continue to talk further. Regulation of growth hormone secretion. After adolescence, secretion of growth hormone decreases slowly with aging. It's almost about 25% of the adolescent level in very old age. Growth hormone is secreted in particular manner. Now, several factors related to person's state of nutrition or stress, which are known to stimulate secretion. First factor is starvation, especially with severe protein deficiency. Next is hypoglycemia. Next is exercise, then excitement, then it's trauma, then ghrelin, which is also known as hunger hormone, and growth hormone also increases during the first 2 hours of sleep cycle. Growth hormone releasing hormone stimulates growth hormone, and somatostatin inhibits growth hormone secretion. Secretion of growth hormone is controlled by 2 factors, which are secreted by hypothalamus, and then it is transported to anterior pituitary through hypothalamic hypophyseal portal vessels. Growth hormone releasing first factor is growth hormone releasing hormone, which is composed of 44 amino acids, and next is growth hormone inhibiting hormone, which is composed of 14 amino acids. Then hypothalamic signals like emotions, stress, trauma, all can affect the secretion of growth hormone. Catecholamines, dopamines, and serotonin increases the growth hormone secretion. Then this flow chart tells us that how higher centers stimulate the hypothalamus. Then hypothalamus releases somatostatin and GHRH, which further stimulates anterior pituitary. And anterior pituitary secretes growth hormone, which acts on soft tissue organs. Then abnormalities of growth hormone secretion. First abnormality is panhypopituitarism during childhood and dwarfism. Panhypopituitarism is nothing but deficiency of anterior pituitary secretion, and dwarfism is mainly due to panhypopituitarism during childhood. Manifestation of these disorders are first is person does not pass through puberty and never secretes sufficient amount of GnRH to develop sexual functions. Next manifestation is weight gain. Next is decreased immunity. The next smaller point is that growth hormone prepared from animals is not effective in human beings. Therefore, the growth hormone of human is also called HGH, which is human growth hormone. And treatment, growth hormone can be synthesized in E. coli bacteria by recombinant DNA technology. Further abnormalities are next is gigantism. Acidophilic growth hormone producing cells of anterior pituitary become excessively active. So therefore, large quantity of growth hormone is synthesized, which therefore rapid growth of tissue including bone occurs. Before adolescence, it leads to increase in height of a person up to 8 feet tall. Next abnormality is acromegaly. Excess growth of acidophilic cells of anterior pituitary after adolescent lead to acromegaly, which causes enlargement of bones of hand and feet, which also causes enlargement of membranous bones and soft tissue organs such as liver, kidneys, and tongue. So this condition, this is the standard condition of a person suffering from acromegaly. Next, I would like to call my friend Shraddha. She will discuss about prolactin hormone.
A very good morning to an